Well, hello again. This time we're here to talk about drugs that affect the pulmonary system. And this picture, I know it's not the most charming picture, but it's actually an excellent representation of what we're trying to keep from happening with many of the drugs that we use in the pulmonary system. This is a mucus plug that was taken out of a patient who died from an asthma attack. And the thing that's so remarkable about it is, first of all, its size. You can see the ruler at the bottom of the picture that gives you some perspective on size. But the other thing that I think is so interesting is that you can see like the detail that is formulated. Like this mucus was so thick and so hard that even when it was taken out of the patient, it didn't just turn into a big blob like you would expect, mucusy mucus to do. This was so firm that it's like a perfect little concrete mold of the descending airways. This is the extreme of what happens to people during an asthma attack. And so hopefully when medications are used appropriately, we can keep this from happening. But it's a nice introduction to the discussion, because in asthma, we often use many of the drugs that you use for all sorts of pulmonary abnormalities. And I mean, look at how extreme this is. Asthma isn't just a condition of bronchospasm or bronchoconstriction. And the reason people wheeze when they have an asthma attack is, imagine trying to breathe through that. And actually, when you get enough of that in your airways, you don't hear any wheezing because you don't have any air movement at all. Anyway, on that happy note, let's back up a little bit. Drugs that affect the pulmonary system. So as always, and I know I say this every week, but it's true, in order to understand how the drugs work, it's really a good idea to have a basic understanding of the underlying problem, what's going on. If I tell you that we use beta-adrenergic agonist and anticholinergic drugs, it just makes more sense if you understand what is the function of the cholinergic nervous system and how the body responds when we give anticholinergic medications. Now, beta-adrenergic agonists, you probably have a little bit better understanding of after last week's lecture. And last week we were talking about beta receptors in the cardiac system, beta-1 receptors in the heart. This week we'll be talking about beta-2 receptors in the lung and the bronchial smooth muscle. So it's, as always, we want to talk about the abnormalities first. And then the second bullet point here says, in common pulmonary conditions, there are a few general things we use drugs for and a few of each type. And it's very true. Unlike the cardiac system, there's like a much smaller handful of drugs here that we commonly use for pulmonary abnormalities. And we just kind of use the same drugs for all the different conditions. Sometimes we just use them in different priorities depending on what the therapeutic outcome is. So think about the pulmonary conditions that you see in your patients. COPD obviously is a common one in the inpatient setting especially. It's not unusual to see patients admitted for an exacerbation of COPD. Lots of times they need ventilation support to get them through the acute exacerbation. Asthma is another one. In extreme and more extreme asthma exacerbations, sometimes it's the reason for admission. Other times patients are admitted with another underlying pulmonary problem that causes an exacerbation of their asthma, and asthma can really complicate their treatment and recovery. Pneumonia, especially in our older population and in the real little pediatric patients, pneumonia can be fatal. And so patients are frequently hospitalized for that. That's community-acquired pneumonia. And then, of course, there's the whole other potential for hospital-acquired pneumonia, which has an appreciably high mortality rate. And hospital-acquired pneumonia, or ventilator-acquired pneumonia, or whatever you call it in your facility, this is the pneumonia that is our gift to the patient. This is pneumonia they develop after 72 hours after being admitted to the hospital, and that virtually always requires inpatient management. And then sarcoidosis, which many people have for years, and then sometimes the sarcoid condition will lead to respiratory exacerbations. It certainly leads to a higher incidence of pneumonia if someone has COPD on top of it. So a lot of times you see them, all sort of tumbling together. Further, if you work in a critical care unit, you have no doubt spent many days managing people who have acute respiratory distress syndrome, or ARDS. It seems like every few years years, that name cycles from adult respiratory distress syndrome to acute respiratory distress syndrome. I think just this minute the A stands for acute respiratory distress syndrome, but I don't know. I don't know if maybe kids don't get it. I've never worked in pediatric critical care, but in any event, whether we call it acute respiratory distress syndrome or adult respiratory distress syndrome, I mean, basically it's just a respiratory distress syndrome. It's a condition characterized by what's referred to as a complete whiteout or complete consolidation of air spaces. Pulmonary embolus, another thing that virtually always requires inpatient admission. And acute respiratory failure, which is different than acute respiratory distress syndrome, not that they don't often coexist. I mean, patients with acute respiratory distress syndrome are virtually always in acute respiratory failure, but you can be in acute respiratory failure without having acute respiratory distress syndrome. I mean, I don't mean for this to be an entire pathophysiology lecture. I know you had another class on that, but I do sometimes like to just take a little time to tease out these basics, because I think sometimes when the basic things aren't clear, it makes everything else a little harder to get your hands around. So just to offer some clarity, acute respiratory distress syndrome is a defined phenomenon where usually because of some overwhelming systemic insult, you get a lot of migration of intravascular products into the air spaces of the lung. You get a lot of migration of neutrophils and macrophages and consolidation. So the air spaces are all full of stuff and you can't exchange air. And that will lead to acute respiratory failure, which is defined as an acute drop in PaO2 under 60 millimeters mercury. I mean, respiratory failure is just a number. When the partial pressure of arterial oxygen falls acutely below 60, you are in acute respiratory failure. That may be because of acute respiratory distress syndrome, or it may not. It may be that you have such a big pulmonary embolus that so much of your gas exchange spaces are not perfused that your PaO2 drops below 60. So that's just a quick distinction of some of the terms. But anyways, regardless of the underlying problem, the drugs that we're going to talk about, the drugs that manage pulmonary conditions, typically center on just these few things: reducing inflammation. This is a big one, whether we're talking about sarcoid or asthma or a COPD exacerbation or acute respiratory distress syndrome or pretty much anything else. Acutely reducing inflammation in the lung is going to facilitate better gas exchange until either we treat the underlying problem or we just wait for it to resolve itself. A lot of those acute episodes, like acute respiratory distress syndrome, we don't really have any defined treatments for the problem. All we do is support respiration and wait for the body to go through its own healing mechanisms. So we have drugs that reduce inflammation. We have drugs that stimulate bronchodilation. And these are, the short-acting ones anyway, are typically referred to as our rescue medications. I mean, whatever else is going on, like I said, sometimes it is just our immediate priority to open up those bronchi so that more air can get through it. And that's what bronchodilator drugs are for. And then we have a whole nother class of medications that block bronchoconstriction. This is very different than bronchodilation. It's kind of like the same principle of arterial constriction and arterial dilation that we were talking about last week. There's one side of the autonomic nervous system, the sympathetic nervous system, that causes bronchodilation. And then the other side of the autonomic nervous system is your parasympathetic side, and that's the side that causes bronchoconstriction. They're two separate things, and there are two separate classes of medication to manipulate them, and we have to consider all of that and understand all of them. So, inflammation, a huge problem in asthma. I mean, it is the primary problem in getting control of asthma, particularly from a chronic perspective. It's the primary issue in asthma and an important secondary problem in most other pulmonary conditions, especially by the time the patient winds up in the hospital. Producing bronchodilation, like I mentioned on the last slide, this is a separate mechanism, and sometimes all we can do is just try to facilitate respiration as best we can while we try to either cure the disease process. Like if the patient has pneumonia, sometimes we have to put them on bronchodilators while we wait for the antibiotics to do their job. If they have asthma, we're putting them on bronchodilators, just trying to open up those bronchi as wide as we can. So there's lots of different roles for it. Sometimes, like I said, we're trying to give the patient a chance to respond to treatment, and other times we're just trying to open up those airways and wait for the body to cure itself. And then finally, blocking bronchoconstriction is a totally separate mechanism and is also important in promoting ventilation. And when the patient is very acute, I mean, when we're talking about an immediate and life-threatening circumstance, we often will just throw everything at the patient initially, get those bronchi open as wide as we can, don't let them constrict at all, and promote breathing. When the patient starts to get a little better and we're not talking about an acute emergency anymore, then blocking bronchoconstriction is something we have to consider if abnormal bronchoconstriction is part of the problem. Keep in mind, bronchoconstriction is a protective mechanism, and we don't just want to go around like arbitrarily giving patients medication so they can't bronchoconstrict anymore. If you can't breathe and it's an emergency, that's what we're going to do. But on a day-to-day basis, you need to be able to bronchoconstrict. Like if something finds its way into your airway that doesn't belong there. Like if you, accidentally inhale some noxious gases or something, if you inadvertently take a deep breath when your face is over like undiluted bleach or something, I don't know. If you suddenly find yourself in an environment where there's like fire and smoke, those are all the things that trigger bronchoconstriction, and bronchoconstriction is indeed a protective mechanism that keeps contaminated atmospheric gas from getting into your alveoli. So we'll talk about all that in a minute or two. All right, finally, we can't forget cough. Cough is another major protective mechanism, and the reason we do it is to keep larger irritants and debris out of the airway. Sometimes cough is necessary but annoying. In fact, you've probably heard me cough a few times through these lectures as I'm just trying to get over a URI. Sometimes cough is necessary. Other times cough is an exaggerated and unnecessary response, and it is helpful to try and control it. But like almost everything the body does, there is a role for it. And so sometimes, you'll find that sometimes when you call the resident or call the attending because the patient wants something for their cough, sometimes they'll give you the order and sometimes they won't. And sometimes they have good reasons for each action and sometimes they don't. But really the proper reason is that sometimes you don't want to impair their protective mechanisms. Sometimes you have to let people cough because it's one of the few ways we have to protect the airway. Sometimes when we recognize that the patient's cough reflex is inappropriate, well then it is appropriate to suppress it a little bit. It's interesting, I have a friend who is a pediatrician, and this person is just absolutely adamantly against protecting cough. He will not give any of his patients cough medicine for any reason. Part of it is because in the pediatric world, there's a real, it's a real big deal that there's not any safety data really to speak of available on using over-the-counter cough and cold medicines on kids under 2 years old. So there's just no data to support it. But aside from that, this pediatrician's philosophy is that nobody ever died from coughing. As annoying as it is, sometimes you'll cough so hard you'll gag, but nobody ever died from it, and yet people have died from having their cough reflex suppressed. So his approach to the world is he just doesn't give it. It always surprises me that the patients still come back, because especially in outpatient pediatrics, parents bringing their kids in for cough is one of the biggest reasons. Like, they want something to suppress the cough. And it's really just a testament to how good this person is that they keep coming back even though he just won't medicate it. So anyways, my point being that cough, like so much else that goes on in the body, so many of those annoying responses, it is a protective mechanism, and sometimes we'll treat it and sometimes we won't. Let's see, what does this slide say? Almost always when patients are, yeah, I think I just said that. I said all of that, so you can read it again. It's an important point. Okay, so let's review the relevant physiology of what happens in the pulmonary tree here. Remember, the whole purpose of the pulmonary system is to get clean body temperature air down into the airway so that you can have gas exchange in the lungs, so that you can put oxygen in to the blood in your pulmonary vasculature and exhale carbon dioxide. So gas enters the pulmonary tree by way of the nose. It's supposed to come in by the nose. Sometimes it comes in by way of the mouth, but the nose is what it's designed for. If you are a mouth breather, you do lose the protective mechanisms in the nose, which are nasal hair. Nasal hair might not be very attractive, especially when it's hanging out, but it is a protective mechanism. Nasal hairs trap the very large pieces of debris found in the atmospheric air. I mean, sometimes, you go outside like on a spring day when there's a lot of pollen and stuff in the air, and you can actually see the stuff you're inhaling. Some of the particles are so large that when you inhale them knowing you're inhaling this big stuff, they get trapped in the air, in the hairs of the nose. It's the first protective mechanism. And so it's an important one, as long as we keep it cleaned and trimmed, right? When stuff gets past the nasal hairs, the next protective mechanism we have are the cough receptors. Cough receptors are located primarily in the trachea. There's some in the larger bronchi, but most cough receptors are in the trachea. This is like protective mechanism number 2. If something is small enough to get past the nasal, something is small enough to get past the nasal hair, or you breathe through your mouth, so you bypass that first protective mechanism, the next protective mechanism you have is the cough, right? Because these are in cough receptors. So the trachea cannot bronchoconstrict. The only way the trachea can protect you from stuff getting into your airway is by coughing. So there's a lot of cough receptors distributed there liberally. And like the second bullet point here says, in general, the only indication to directly suppress the cough reflex or the neural centers in the brain that control it is when the patient is intolerant of cough from an oxygenation perspective. So this is a purist perspective here, and it's true. If somebody is coughing so much that their PaO2 falls to a level where you're concerned about their oxygenation, and this may happen in somebody with COPD, or, like cystic fibrosis or other, really pulmonary diseases that really inhibit gas exchange, then sometimes it is appropriate to suppress cough. But again, from a purist perspective, otherwise we're supposed to let cough do its job. So once air from the atmosphere gets past your nose hair and gets past your cough receptors, anything that gets past those two defense mechanisms is relatively small. I mean, presumably anything that's relatively big in terms of inhalation will get trapped in the nose or coughed out. But there still may be some small debris in the airway. The next stop along the way of your ventilation system are the large bronchi, the main stem bronchi and bronchioles, and their mechanism of protection are goblet cells and cilia. That's how they work to, again, protect your airway, because the whole role of your conducting airways, again, is to get clean, humidified air, cleaned and controlled to body temperature, so that by the time it gets into the alveoli, which are the gas exchange airways, it is of the right temperature and cleanliness to exchange gases. You don't want any debris in the alveoli, because the only way your alveoli can protect itself then is to have an inflammatory response, and then your alveoli get inflamed, and that's no good. So that's why we got nasal hairs, why we have cough receptors, and then in the bronchi and bronchioles we have goblet cells and cilia. So you know what goblet cells do? They make mucus. These are your mucus cells. And we are all constantly producing mucus, because even in a healthy state, we are all constantly inhaling some small amount of some small little things that make it, past every other mechanism, and they get down to the bronchi, and then the bronchi make mucus and trap them, and the cilia take that mucus and beat it towards the mouth. They beat it towards the oropharynx. And then and of course every time I say this we all start swallowing. Then the stuff gets up there and then you swallow it. And in the healthy state, like how most of us are now, even though I am getting past this URI, most of us are healthy, and so this happens in such minuscule amounts that we don't even realize it's happening. But all of us right now have some goblet cells somewhere that are making mucus, trapping debris that found its way into our airway and beating it up to our throat so that then you can swallow it and excrete it out the other end. Glamorous, isn't it? Again, this is a defense mechanism, happens to us all the time, and we are constantly swallowing it along with saliva. If this inhaled debris manages to get past the nasal hair, past the cough receptors, and is so small that it doesn't even get trapped in mucus. We presume that it is less than 1 micron in diameter. I mean, you can't even see it. Then it will get down to the alveoli, which is where we don't want it, because again, the air in the alveoli needs to be clean so that it can participate in gas exchange. If something gets all the way down to the alveoli, the only thing that we can do then is incite a macrophage response to eliminate it. If this happens repeatedly, as it does in any case of people who keep exposing their airways to irritants, then you will get more and more macrophage-mediated consolidation of the small airways, and your macrophage will distend those airways and they become permanently inflated and unusable. The example that your handout gives you is smoking, because smoking is obviously the most common one. What you inhale when you smoke a cigarette is for the most part smaller than 1 micron. But you know how, I mean, if you've ever smoked, you know how it goes. If you smoked and you remember back to when you first started, you did probably cough your brains out when you started smoking. But like anything else in the body, if you keep exposing yourself to it, you will become desensitized to it. So eventually, the cough receptors in the trachea become desensitized, and you will make more mucus. Right? Smokers do generally make a little bit more mucus, even if you don't realize it, but something is going to get down to the alveoli. And if it gets down to the alveoli and you do it like 20 to 40 times a day for 30 or 40 years, eventually there's going to be so much inflammation in those alveoli that many of them become unusable, and that's what COPD is. But smoking is just one example. There are people who don't smoke that get COPD, and I think that's important to mention. People who, like in the little rural clinic I work in, I have a lot of miners, people who spent years and years in the mines before everybody was, really active about protective gear and stuff like that. People who worked with asbestos. People who worked a lot with, what's the word I want, like textile workers, like occupational, like industrial strength cleaning solvents and things like that. Like people now, it's not so much an issue now because everything's computerized, but for decades, people who worked in like film developing and stuff like that, when you're constantly exposing even to noxious gases, you don't always realize it, but they are exposing, they're getting into your alveoli, and your alveoli don't want them there, and macrophage activity will ensue. So again, my primary point is smoking is the easy one. It's the example we all point to, but do keep in mind that there are other things that people have exposed their airway to over the long haul that leads to chronic pulmonary disease in the end because of this chronic macrophage activity. And then the last piece of pulmonary physiology that we have to review as a foundation for drug therapy is the autonomic nervous system, right? The sympathetic and parasympathetic influence. So, I'm sure I've mentioned this already. Under normal circumstances, it is the sympathetic nervous system that dominates the bronchi. Remember, we have the autonomic nervous system, which is part of the central nervous system, and the autonomic nervous system has two branches, the sympathetic and the parasympathetic. And they each innervate virtually every body system and exist in a balance that allows us to function day to day, and then allows us to function differently in extremes of physiologic circumstances. The sympathetic nervous system in the case of the bronchi is the one that dominates. So under normal circumstances, our airways, our lungs are swimming in epinephrine. Epinephrine binds to beta-adrenergic 2 receptors and produces a sustained state of bronchodilation. So in the typical normal day-to-day state, the bronchi are maximally dilated. Well, I shouldn't say maximally dilated. They definitely have the potential to be more dilated, but in the day-to-day, they are dilated enough to offer no meaningful resistance to inward and outward airflow. I mean, obviously you're experiencing this right now. As I'm sitting here talking and you're sitting there listening, obviously there's enough epinephrine doing its job. The air is going in and out, and we're not even aware of it. That's the steady state. That's the way it's supposed to be. The lungs do have aggressive parasympathetic innervation, and just like the sympathetic nervous system is beta receptors and epinephrine, the parasympathetic nervous system in the lung is comprised of muscarinic receptors and acetylcholine. Acetylcholine is the parasympathetic neurotransmitter, as epinephrine is the sympathetic neurotransmitter. And under normal circumstances, we don't have acetylcholine. Our lungs are not swimming in acetylcholine. I mentioned a minute ago, our lungs are like swimming in epinephrine. They are not swimming in acetylcholine. If they were, we would constantly be bronchoconstricted. What we have is acetylcholine on standby, maintained inside the nerve endings of the parasympathetic nervous system to be released immediately if it has to. So if you suddenly, like you were preparing to clean something and you just weren't thinking and you didn't dilute your bleach right, and you poured bleach in a bucket and then without thinking turned around and your head was right over and you inhaled, you will immediately start coughing, because you will immediately bronchoconstrict because your airway perceived that something was trying to get in that shouldn't belong there and released acetylcholine. And acetylcholine binds to those muscarinic receptors and causes virtually immediate bronchoconstriction to protect your alveoli. Now, I don't advocate trying that. Please take my word for it. That's what's going to happen. The point being, while we are constantly under sympathetic nervous system influence, our lungs are not constantly under parasympathetic influence. It's just there waiting to be needed. If we don't need to bronchoconstrict today, we won't release any, acetylcholine. So this slide also probably says what I just said. Naturally at rest, we don't want bronchoconstriction, right? So there is no parasympathetic influence. It is definitely an on-demand phenomenon. It should only happen when there is something trying to find its way into the airway that the airway doesn't want there. Because like I said, in the final analysis, the entire ventilation system from nose, mouth, oropharynx, trachea, main stem bronchi, bronchioles, all of the conducting airways, they just exist to conduct. Their whole job is cleaning and filtration, and that's why we have all of these different protective mechanisms. And then in the alveoli themselves and the gas exchange airways, all we have is macrophage activity. So the parasympathetic response, it's just there to protect us when we need to. Oh yeah, your slide says like in the case of drowning, which is of course an immediate need. I gave you lots of examples of like gases and cigarettes and things, but another one, I'm sure everybody can relate to having once in some point in your life aspirated some fluid that you were drinking. And you know what happens when you try to aspirate a fluid that you're drinking, right? You'll start coughing and coughing and coughing because you've had a parasympathetic release that causes bronchoconstriction. So in treating common pulmonary disorders, we're trying to inhibit the inflammatory response, we're trying to inhibit parasympathetic bronchoconstriction, and we are trying to acutely bronchodilate it. And like your slide says, usually we're trying to do like all of these things at one time or more than one of them at one time. So let's take some time now to look at the drugs that do it. First up, beta-adrenergic agonist. Beta-adrenergic agonist, not to be confused with the beta-adrenergic antagonists that we discussed in the cardiac system. Now we're talking about beta-adrenergic agonists, and these are all synthetic forms of epinephrine. This is the only class of medication that will produce immediate bronchodilation, and by immediate, I mean in a matter of minutes. These are rescue drugs. When patients are having some sort of acute pulmonary episode and can't breathe, they will almost always have an albuterol treatment referred to as a neb treatment. This is nebulized albuterol because this is the one that will dilate even more. A few minutes ago, I mentioned that as we're all sitting here, we are bronchodilated. And I said maximally dilated, and then I corrected myself because we're not maximally dilated at rest. We're as dilated as we need to be to facilitate healthy gas exchange. But if you have a patient, you may have a patient, remember, the sympathetic and parasympathetic nervous systems are two very separate things. So you may have somebody who has, their epinephrine is doing its job, but they're having bronchoconstriction for some reason. If we give them an inhaled beta-adrenergic agonist, then we do maximally dilate their airways. So giving somebody a beta agonist is like giving them synthetic epinephrine. What we're trying to do is dilate every single bronchi cell that we can. This is the only rescue drug we have available. Whenever you hear people talk about rescue drugs, we are talking about short-acting beta-adrenergic agonists. The beta-adrenergic agonists do come in short-acting forms and long-acting forms. The short-acting form is the one you're most familiar with. This is albuterol and all of the albuterol. There's a ton of brand names. There are long-acting forms of beta-adrenergic agonist. And it's important to point out that they are not rescue drugs. They're used for different reasons therapeutically. So here you go. Short-acting forms are the rescue version, albuterol and all of its knockoffs, and these act like epinephrine. They bind to beta-2 receptors and cause immediate bronchodilation. The long-acting forms, they're formulated to be like for sustained release in the body, so they won't acutely bronchodilate you. The ones that you might be familiar with in clinical practice are salmeterol, which is marketed as Ceravent, and then there's formoterol, which is marketed as Foradil. These are long-acting beta-adrenergic agonists, but they are not rescue therapy. A real important part of patient education, especially if you're discharging someone who has been admitted, say, for an asthma exacerbation or a COPD exacerbation or whatever, if they're being discharged on combination medications and there's a rescue medication and then a non-rescue medication, one of the most important things you can do for that patient is to make sure they understand the difference between the two. Make sure if they have an inhaler that they're supposed to use every day just for chronic control of a disease, like a salmeterol, a long-acting beta agonist, it's very common for patients with COPD, say, to be discharged on salmeterol to be used every single day, whether they need it or not, and then an albuterol inhaler to be used only when they feel acutely short of breath or acutely wheezing or acutely coughing. It really is critical that they understand the differences between the two, because lots of people will reach for the wrong one when they're having an acute episode, and there are deaths related to that every single year. So patients and you want to know the difference. Short-acting beta-ags, they are your rescue med, and they're the only rescue inhaler there is. What else do we have about beta-adrenergic agonists? They work by mimicking epinephrine. Yep, they're synthetic epinephrine. That's why they're safe for babies and they're safe for everybody, because these are just an administered form of a naturally occurring hormone. Everybody can tolerate epinephrine. Now, epinephrine, it is like giving yourself an epinephrine bolus. So a lot of times when people use these, they feel the effects of sympathetic stimulation. They might feel tachycardic. They might feel like their heart is pounding. They might feel tremulous or a little bit agitated. All those things that happen when you have a lot of epinephrine on board. Oh, so that's what this bullet point here says. Consequently, they will cause other sympathetic responses. This hormone, this is a synthetic or administered form of the naturally occurring hormone epinephrine that is mobilized when you have fear, flight, or fight. So just think about what happens when you get stressed, how you feel, maybe a little tremulous, a little agitated, little anxiety, right? Maybe a little palpitation. Those are the same kind of things that can happen to patients who take an albuterol treatment. Here you go. So this shows you what, this shows you what epinephrine can do to you. In its naturally occurring form, when you are under a physiologic stressor, you release epinephrine from your adrenal gland and it activates your sympathetic nervous system. So when you administer to a patient a beta-adrenergic agonist, especially a short-acting one, it stimulates all the things that body system does. So let's see. Breathing rate increases, blood flow to skeletal muscles. You're preparing your body to fight a stressor. Now, when we give people this for, an asthma exacerbation, all we want is bronchodilation and breathing rate increases, but the rest of this stuff is going to happen incidentally. Heart rate increases, blood sugar, because when you are having a stress response, epinephrine mobilizes glucose, because glucose is your immediate source of energy, right? Glucose is brain food. It's the energy source that your body can metabolize very quickly. Blood pressure increases because when you're having a stress response, you need more blood to the brain. Your pupils dilate because you need to be able to maximally see around you. maximize your peripheral vision, and your intestinal muscles relax. You don't want your intestines contracting when you're having a fear, flight, fight response. I feel like I mentioned this in last week's lecture. In what context, I don't remember. But when you're having a fear, flight, fight, you certainly cannot be troubled by the need for a bowel movement, right? You can't be hungry. And, think about it. When you're really stressed over something, most people will say, oh my God, I couldn't eat. Like if you have a major test that's stressing you out or something, or you have to like give a presentation or whatever, and you're stressed out, like the thought of food is like anathema, right? It's the last thing you want. It's because your intestinal muscles are clamped down because you're fearing flying. All of your body's attention is prompted to perfuse your brain, perfuse your lungs, all the important stuff. Anyways, that's what albuterol treatments, especially if the patient's like if you're in an emergency room or an urgent care or on a hospital floor and you have to give the patient a couple epinephrine treatments, you'll watch them. They'll get all tremulous and stuff. They usually look all cracked out after using a few of these. But they can breathe, which is the important thing. All right, let's see. This diagram differentiates the sympathetic from the parasympathetic nervous system, so that's useful. And I'm not going to go through the whole sympathetic nervous system here, but this just draws the contrast that the sympathetic nervous system dilates the bronchi, which is what I keep saying. It does all these other things too. Many of them we've already talked about. Dilates pupils, inhibits any digestive activity, inhibits salivation, hence the dry mouth. Somewhere in here it will say inhibits digestion, which means inhibiting bowel movements, inhibits peristalsis, no sudden urges to have diarrhea when you're stressed. Conversely, the parasympathetic nervous system, this is like the anti-fear, flight, fight. The parasympathetic nervous system is the part of the central nervous system that maintains the day-to-day stuff. It's not glamorous and it's not sexy like fear, flight, and fight, but it's just the day-to-day things that keep you alive, like stimulates digestion, contracts your bladder so you can urinate, stimulates peristalsis so that you can eat and have a bowel movement, stimulates salivation. It slows down your heart rate because you don't need to be having a heart rate of 95 beats a minute when you're just like sitting around eating, or you're just, sitting around studying or doing something that's not a fear, flight, fight response. The parasympathetic nervous system, like I've mentioned, is the one that allows for bronchoconstriction, which you don't need at all on a day-to-day basis. You only need it if your lungs are threatened. Just like the sympathetic nervous system is frequently referred to as fear, flight, fight, the parasympathetic nervous system is referred to a lot of times as the SLUD response, S-L-U-D, salivation, lacrimation, urination, and defecation. Not very glamorous, to be sure, but those are the day-to-day things that, boy, when you can't do them, you become preoccupied with it. I mean, we all take for granted the ability to salivate, but if you lose the ability to salivate, number one, excuse me, you'll become preoccupied with it, with dry mouth. It'll be the thing you think about all the time. You'll be like running around drinking water, chewing gum, eating mints, just everything to try to relieve that dry mouth. You become consumed by it. Also, when you don't make your salivary enzymes, it can't control the flora environment in your mouth. It puts you at higher risk for tooth decay. It puts you at higher risk for obstructions in your salivary glands and like mouth sores and stuff like that, and for bad breath because it doesn't control the normal flora in your mouth. Salivation, lacrimation is another one. Lubricating your eyes. Lubricating your eyes is also not something that you think about on the day-to-day basis, but when you can't do it anymore, you will become consumed by it. When you get dry eyes, minimally, you'll find that every little irritant in the air bothers your eyes because usually lacrimation, if some little thing in the atmosphere gets in your eyes, you don't even notice it. You lacrimate, you get rid of it, and that's the end of that. It's so second nature as you don't even realize it. But if you can't lacrimate, your eyes become much more prone to irritation and even at risk for iatrogenic corneal abrasion because when they're dry, they're more subject to abrasions even from just rubbing them. So it's like salivation. You don't think about it until you can't do it anymore. Salivation, lacrimation, urination, and defecation. Well, if you can't defecate, you're going to become consumed by that. We all do. And if you can't urinate, that's just not going to fly for very long. You get like 12 hours under your belt without passing urine, and your body's going to know it, and then soon you'll wind up in an emergency room getting cathed. So salivation, lacrimation, urination, defecation. Those are the things that the parasympathetic nervous system is constantly maintaining. And then, of course, the parasympathetic nervous system is the thing that keeps your eyes appropriately constricted to the environment. You don't want them dilated all the time. You surely don't want them dilated when the sun is shining in them or when you're outside. It's actually very painful. So parasympathetic just maintains that day-to-day unglamorous, stuff. Sympathetic is your cool guy, fear, flight, and fight. But the point of this slide is that there are two very separate systems. They are maintained by two different neurotransmitters. Sympathetic is epinephrine, parasympathetic is acetylcholine, and so two different sets of medication to control them. So the anticholinergics are the drugs that block the activity of the parasympathetic nervous system. So again, keeping in mind that the parasympathetic nervous system is really just in place to protect us, and for most people, it's not even activated. So if we took an anticholinergic, an inhaled anticholinergic medication targeted toward the pulmonary tree, it really wouldn't do very much because there's not much going on anyway. But if you have a condition that is characterized by more constant stimulation of the anticholinergic system, then it would block one of the stimuli that helps your lungs to bronchoconstrict. The cholinergic system also promotes mucus secretion, and anticholinergics will slow that down. Sometimes the anticholinergic release happens inappropriately, and that's what anticholinergic drugs are for. And your slide says sometimes it happens inappropriately, asthma, and sometimes we need to block it to maximize the airway, and it's COPD. And anticholinergic medications block acetylcholine receptors. So it's true. Sometimes in asthma, when you're having an asthma exacerbation, when you're having an asthma attack, the parasympathetic nervous system, all of your defense mechanisms are just they're happening inappropriately. They're happening too much. So we give anticholinergics to block it. There really isn't a role for anticholinergics like in day-to-day chronic asthma management, but in an acute asthma exacerbation, remember that diagram that was on the cover slide of this discussion, that mucus plug? That mucus plug is like the ultimate result of all of your parasympathetic nervous system mechanisms going into overdrive. Because when your lung perceives that something is in it that doesn't belong there, several things happen. One of them is the cholinergic response of hypermucus secretion. You'll make more mucus because your lung thinks you need it. You will bronchoconstrict because your lung is trying to keep anything from going down further. You'll breathe faster. You'll become tachycardic, or tachypnic, not tachycardic, although that might happen too, but you'll become tachypnic because your body knows that you're having a harder time oxygenating, and its response to that is to breathe faster. And by breathing faster, you will dry the airway out. So in an uncontrolled asthma exacerbation, what's going on is excess secretion of mucus, drying because of tachypnea, and bronchoconstriction. Think about what you're doing. You're making mucus, you're drying it out, and then you're constricting around it. And that's what makes those mucus plugs in asthma, and that's what we absolutely don't want. So during an acute exacerbation, sometimes we do need to help control that inappropriate cholinergic response. COPD is a different disorder. And it's not asthma. It's not a disorder of inappropriate cholinergic responses. But there is a theory that in patients with COPD, because they have chronic crud in the airway that doesn't belong there, they have like a chronic low-level stimulation of the cholinergic protective mechanisms, and we use anticholinergics to try to control that. So these are our two anticholinergic medications. We also have short and long-acting, just like we had short and long-acting beta-adrenergic agonist. Remember, the short-acting was albuterol, and the long-actings were Ceravent and Furadil. In the world of anticholinergics, the short-acting one is Atrovent, which is the brand of ipratropium bromide, and the long-acting one is tiotropium bromide, which is marketed as Spiriva. And the same rules apply. The short-acting one is the one that's going to work right away. The long-acting one is the one that is formulated for a sustained release approach. So if somebody's having an acute asthma exacerbation, how you'll see them treated is with albuterol nebulizers alternating with ipratropium nebulizers. We're looking for the short, immediate response. In patients with COPD who are not having an acute asthmatic response or having acute bronchoconstrictive response, you won't really see much of a role for Atrovent, but Spiriva is used every day to try to give like some low-level control of that cholinergic response. Both Atrovent and Spiriva are inhaled, so they're not absorbed systemically, so they don't have any like systemic anticholinergic effects. They're not going to have any effect on the parasympathetic nervous systems like on the rest of the body, you know, like an oral medication or an IV medication would. These impact primarily the lung. Oh, here we go. Look, I got excited and got ahead of myself. Here's even that picture again. So I'm sure I've already answered this. Let's see what the slide says. Think about asthma. What are the cholinergic responses? Yep, just told you that. Increased mucus production, bronchoconstriction, and then tachypnea and drying. How do ipratropium and tiotropium impact them? Well, ipratropium is the short-acting one, and that's the one that impacts immediately. That's your rescue, one of your rescue therapies with an exacerbation. Tiotropium is long-acting, and it's not gonna rescue somebody from an acute asthma attack. This is the one that we use every day. So again, you can see how patient education is so important here. One of the foundational things is that patients need to understand the difference between these short-acting and long-acting agents because they both have two very different roles. There are lots of other medications that are not respiratory medications at all, but they're given systemically and they have anticholinergic properties. And drugs with anticholinergic properties can interfere with the airway's ability to protect itself. It can interfere with the cough reflex, and they can interfere with the ability to bronchoconstrict. And again, these also have implications for the patient, especially patients that have respiratory disease. So here you go. Here you go. Tricyclic antidepressants. We will talk about these some weeks down the line from now. But tricyclic antidepressants are very powerful anticholinergic medications. They block the parasympathetic responses in many body systems. First-generation antihistamines too, from the over-the-counter ones like Benadryl to the ones that we give, in the inpatient setting or give by prescription, like meclizine or Vistaril is also an antihistamine. The opiates. All the opiates have anticholinergic properties. Antidiarrheal medications, I mean, the best ones, the way they work, the intended therapeutic action is that they block the cholinergic response. Because remember, the cholinergic response activates the gut. So, of course, if you want to slow down diarrhea, you slow down gut activation. And the bladder antispasmodics, there's a bunch of them out there. Vesicare is one of them. I can't believe it. Ditropan is another one. These are all drugs that are used for urge incontinence because it's cholinergic stimulation that makes the bladder contract. So if you want to slow that down, you give an anticholinergic. I think the next slide is the picture again. Yeah, here we go. So this illustrates for you all of the parasympathetic responses. Now the respiratory drugs like Atrovent and tiotropium, they don't impact all of these because they are inhaled and they only target the lung, which is exactly what we want. But when you take things like a tricyclic antidepressant like Elavil or a bladder drug or Lamodal to stop diarrhea or Vistaril, to help suppress nausea, it can affect all of these things. So it blocks parasympathetics. It blocks the ability of your pupils to constrict, blocks salivation. Many people with antihistamines and opiates and all of those drugs will complain of dry mouth. Because the parasympathetics slow the heartbeat, when you give people drugs that have anticholinergic activities, you block the ability to slow heart rate, so the heart rate will speed up, and they often become either higher normal or tachycardic. So for people that have underlying rhythm problems, this can be a problem. This parasympathetics, remember, stimulate digestion. So the anticholinergics, which are anti-parasympathetics, will block that. They will slow down the gut, which is good if you have diarrhea, but it's not good if you don't. Stimulates bile release, so you block the ability to do that, so it becomes harder to digest fatty foods, and like all of these things that we've already talked about. Those drugs from the preceding slide, tricyclic antidepressants, first generation antihistamines, because they're the ones that cross the blood-brain barrier, all your opiate medications, your antidiarrheals, and there's other ones too. I mean, there's a lot more than just what's on that slide. If you take a systemic drug that has anticholinergic properties, it's going to block many of these parasympathetic responses. Okay, now we're going to switch gears a little bit and talk about drugs that suppress inflammation, because remember, I mentioned that that's another one of the things that we do with respiratory medications. So the inflammatory response, and we're going to diagram it in the next slide or so here. The inflammatory response is what happens when some foreign object or foreign particle gets in your airway. It is a protective mechanism that helps maintain the purpose of the pulmonary system, right, which is to get clean, filtered air down to your gas exchange spaces. The inflammatory response is separate from parasympathetic activation, but they typically work together. It's not like one or the other. If something gets in your airway that doesn't belong, the cholinergic response will try to neutralize it. If it doesn't, if something stays there that doesn't belong, you will incite an inflammatory response, and that's what is the target of some other medications. Like with everything else that happens in almost all sick people, sometimes the inflammatory response is very appropriate. I mean, it's the way that your body gets rid of things that don't belong there. And most of the time, in healthy people, the inflammatory response is something that we want to happen, and we let it go, only interfering with it when the benefit outweighs the risk. Finally, the last bullet point here says sometimes the inflammatory response is inappropriate and we have to suppress it. So to try to give that a little bit of clinical context, yes, if a patient has pneumonia, we want them to have an inflammatory response. We want their inflammatory response to help get rid of the bacteria. Now, the inflammatory response will make you feel bad. If it just makes you feel bad, we let it go. If it's going to hurt you, like if your respiratory status is already tenuous or already compromised even before you had pneumonia, say, and that inflammatory response can kill you, then we will suppress it. And by the same token, in some conditions, the inflammatory response just shouldn't be happening at all. So again, to try to put this little context for you, patients with pneumonia, like if you or I get pneumonia and we don't have any pulmonary disease, we are going to have an inflammatory response, and it's going to give us a fever, and that fever is going to give us muscle aches and headache, and we're just going to feel crappy. But at the same time, that inflammatory response is helping get rid of the bacteria in our lungs, so we just let it go. The thing to do is let it go. Of course, everybody's knee-jerk reaction is to take Tylenol and Motrin for the fever, which kind of is counterproductive because then you're suppressing the inflammatory response, but you know, that's the way 21st century lifestyle is. But in a healthy patient who is otherwise healthy except for this pneumonia, we should let it go unless the inflammatory response really begins to present its own health challenge. Now, if you're an 85-year-old lady and you get pneumonia and you develop an inflammatory response, and now the fever is really putting you at risk for clinically significant volume contraction or clinically significant metabolic wasting. I mean, if you're a little old lady and you don't have any body fat to spare, and then you have a couple days worth of fever, that's going to burn calories at a huge rate. I mean, when people are sick with fever, you can just watch the weight fall off them. Like for some of us, it's awesome. But if you're a little old lady who doesn't have any weight anyway, it can be very dangerous. Well, yeah, in that circumstance, we should suppress inflammation. By the same token, if you have underlying COPD and now you get pneumonia and the inflammatory response can kill you. We need to suppress inflammation. So that's a circumstance where the inflammatory response is normal, but sometimes it's appropriate to suppress it. By the same token, sometimes inflammation is flat out abnormal, and that's really what asthma is. Asthma is an inflammatory response that is happening inappropriately in the patient's airway, so then it's very appropriate to suppress it. I mean, that may, sometimes you'll notice that you'll see physicians prescribe drugs for one case, and you think, okay, well, that's the way you treat that. And then somebody else comes along with what you think is the same condition, and they don't prescribe the same drugs. And the considerations are the risk-benefit ratio in any individual patient. All right, so let's look at the inflammatory response here. So this is what happens, right? The antigen is the irritator. So we're talking about airway, so the antigen would be the thing that gets in your airway, whether it's cigarette smoke or an allergen from the environment or whatever. And the antigen immediately stimulates beta cells to produce IgE, and IgE will stimulate mast cells. And when mast cells are stimulated, several things happen. Number one, they release histamine, they release leukotrienes, and they release other pro-inflammatory mediators like cytokines. They each go on to do their own thing to perpetuate this, what's supposed to be a healing response. The pro-inflammatory mediators stimulate T cells. T cells will liberate neutrophils, eosinophils, which will go on to activate and cause inflammation in their own right. At the same time, macrophages will be part of that inflammatory response, and then the histamines and the leukotrienes will cause bronchospasm in an effort to protect the airway. So all of these things are a function of the inflammatory response. We have different medications that can impact different pieces of them. Antihistamines are one of them, and you should be able to pretty easily figure out what antihistamines do, because that diagram that we just looked at showed histamines causing bronchoconstriction. So if we give a patient an antihistamine, we block the effects of histamine. The mast cell still releases histamine, but it can't cause bronchoconstriction. We block the place on the bronchial cell where the histamine would do its job. So that's one important piece of interfering with the inflammatory system. We have, in the world of antihistamines, we have several excellent ones to choose from. We have those that are sedating and those that are non-sedating. Sedating antihistamines are sometimes called H1 receptor antagonists, and they are sedating because they can cross the blood-brain barrier. It's just the structure of these drugs that they can cause the blood-brain barrier and block histamine receptors in the brain, and one of the adverse effects of that is that it makes you tired. Diphenhydramine, is generic Benadryl, and we know that that can make you tired. Benadryl is used to facilitate sleep. It is the active ingredient in all of these over-the-counter sleeping aids like Tylenol PM and Excedrin PM and that kind of stuff. Meclizine is the generic name for Antivert, the drug for vertigo. Chlorpheniramine is another like over-the-counter first-generation sedating antihistamine, like in the Benadryl family. And hydroxyzine is the generic name for Vistaril, which is also a non-sedating antihistamine. These drugs are a sedating, not non-sedating. These are sedating antihistamines. Hydroxyzine is frequently used to suppress nausea because that's one of the other benefits of antihistamines that cross the blood-brain barrier. They can help neutralize the vomit stimulus in the vomit center of the brain. The non-sedating antihistamines are non-sedating because they don't cross the blood-brain barrier. So there's pluses and minuses to that. The plus is obviously it's non-sedating. So if you need an antihistamine to suppress respiratory symptoms like allergy symptoms, and you have to go to work or you have to drive a car, or I don't know, maybe you like work with knives or heavy equipment or whatever, then non-sedating is good because it doesn't put you to sleep. By the same token, they don't cross the blood-brain barrier, so you cannot use these to help suppress nausea. And they're not going to be useful as like a Tylenol PM kind of thing. So there's pros and cons to both of these. Neither one is any better at blocking the effects of histamine than the other. They're both theoretically considered equally efficacious. In my experience, personally, I find actually the sedating antihistamines to be better for suppressing respiratory symptoms, and it can be very useful. Like if you have allergies and they tend to flare up at night in your bedroom, maybe you have an animal or something that sleeps in the bedroom, and you love the animal, but they kind of get your allergies going. If you take a couple of Benadryl before bed, it can have the added advantage of both suppressing your histamine-mediated symptoms and helping you fall asleep. Okay, so blocking histamine receptors, this is probably everything I just said. Blocking histamine receptors decreases the available stimulus for, blocking histamine receptors decreases the available stimulus for results in bronchoconstriction. Apparently there's a word or something missing there, but hopefully you get the idea after we just talked about it. If you block histamine, you're blocking one of the stimuli that can cause bronchoconstriction. So it works after the trigger has occurred. That's why these are like rescue therapy. These are like, if your allergies are acting up, you take an antihistamine. It blocks the effects of histamine. Antihistamines will not control anything. All they do is help manage the symptoms when, after the symptoms have occurred. So it's not like you take an antihistamine every day to try to keep your allergies under control. You take an antihistamine on any given day that your allergies are flaring up. If they just flare up once in a while, that's fine. It's a perfect way to manage it. If your allergies bother you every single day, then an antihistamine every day is not the thing to do. Then we have other medications for that. And again, like I said, the first generation antihistamines readily cross the blood-brain barrier, so they can produce sedation. They also, I didn't mention this on the other slide, but they also actually can help suppress a cough. Even though I said a little while ago that suppressing cough is not typically one of the top things we want to do when patients, say, have a URI, but if they're coughing excessively and you want to help suppress that, it's very appropriate to put the patient on a medication that has a first-generation antihistamine in it, and it will help suppress cough. And if they're having trouble with vomiting, well, they'll help suppress that too. And again, like I said before, second-generation antihistamines don't cross the blood-brain barrier, so you don't get any of those benefits of crossing the blood-brain barrier. Speaking of cough, of course, I have to now. When you think about the adverse effects, the things that, patients will ask you, will this drug do this to me? Or, maybe you want to give them a second generation, a non-sedating antihistamine, and the patient says, oh my gosh, is that going to make me tired every time I take an antihistamine? It makes me really tired. These are the considerations when you're doing patient education. First generation antihistamines, yes, they potentially have further reaching side effects because they cross the blood-brain barrier. They also can be a little bit anticholinergic. Remember, a little ways back, we were looking at a slide that showed the impact of the cholinergic system all over the body. And I said when you give anticholinergics like opiates or tricyclic antidepressants or antidiarrheals, and I forget what else was on that slide, they all have anticholinergic properties. Well, so do first-generation antihistamines. They're not profound, but they really can tip somebody over the edge. Like, if you have a little trouble, like say you have diabetes and you have a little bit of trouble with neurogenic bladder and some urinary retention, if you take an antihistamine, it can make that urinary retention worse. If you have a male patient with prostate hypertrophy and they have a little bit of a trouble getting their urinary stream started, and an antihistamine can make that worse. So sometimes these anticholinergic effects, they can be a significant factor, but usually only if coupled with other risk factors too. All right, next class of drug of interest are the leukotriene receptor antagonists. So this is a pretty specific type of medication. If you've heard of any of them, there's a couple that are approved in this class, but if you've heard of any one, it would be Singulair. Singulair is the brand name for the medication Montelukast, and it is a leukotriene receptor antagonist. So it can help interfere with bronchoconstriction from another perspective. See, this is that diagram that we looked at a few minutes ago, and now you've got a big red arrow pointing to leukotrienes. Leukotrienes are another trigger that can cause bronchospasm, and they're pretty specific. That's pretty much all the leukotrienes do, is trigger bronchospasm. So if we're trying to help neutralize bronchospasm, leukotriene receptor antagonists are a good choice. These drugs are used mostly for allergies. So if you have a patient who's, allergic asthma, then a leukotriene receptor antagonist like Singular might be a new drug that's introduced to them, to manage their illness. And when they ask you questions about it, that's what you want to tell them. Very specific, very safe, doesn't have much impact on the rest of the body, but can help control that, inappropriate or exaggerated bronchospasm. Yeah, everything I just said is right here. Again, they're like antihistamines in that they don't cure the problem. They just provide some control so the patient can get through the day. Leukotriene receptor antagonists, though, unlike antihistamines, you can't see it from that diagram, but histamine does a lot of other things too. Leukotrienes really just do precipitate bronchoconstriction, and so they don't have anticholinergic side effects or anything else. So they are intended to be used on a daily basis for people that have more serious allergic problems. They're not like they should just be used once in a while. Those are prescription medications, and they're intended to be used on a daily basis for people whose asthma, or people whose allergies or allergic asthma is so significant that they need to take something on a daily basis to keep it under control. But in terms of side effects, they're really, really very easy to take. All right, next we got the corticosteroids. So corticosteroids come in many forms. They come in inhaled forms, things like fluticasone and budesonide, you might know as Flovent and Pulmicort. And they also come in oral forms, which you probably know as prednisone or prednisolone. The corticosteroids also are prescribed as like a Medrol dose pack or Solumedrol. They're available IV. There's all kinds of them. So these drugs, they do suppress inflammation, but they have a very different role and very, very different implications. These suppress inflammation much earlier up in the cascade. Whereas the leukotriene receptor antagonists are very focused to leukotriene-mediated bronchoconstriction, if you give somebody a corticosteroid, you're suppressing inflammation much earlier, which means there's a whole lot of other things that you interfere with. The thing about most reactions in the body is that they're kind of amplified. You have the first step, and that triggers a few things, and then each of those few things triggers a few more things, and it kind of looks like a Christmas tree. The effect just gets wider and wider and wider. Antihistamines and leukotriene receptor antagonists, they just affect one relatively small area about 2/3 of the way down that tree. Corticosteroids suppress inflammation from the top of the tree, so they suppress all of those amplified responses, and they can have impacts that have absolutely nothing to do with pulmonary, with breathing. They block the formation of many of the precursors that go on to trigger mast cell stimulation. And last bullet point is what I just said. Systemic corticosteroids block inflammation in virtually all body systems. So, if the patient is flat out can't breathe and is so inflamed that you need to do something global and urgently, that's what we use systemic steroids for. If their problem's not that bad though, we try to stay away from it, and you'll find that people don't really get systemic steroids prescribed for respiratory problems unless they're really having a pretty acute problem, they really need some immediate help. Let's see. Corticosteroids are available in both inhaled and oral form. There I went again, getting all excited and getting ahead of myself. Everything I just said is right here. Obviously, inhaled steroids, they don't have the same effect on the rest of the body because they're not really systemically absorbed from the lung. They are they're topical medications. It's like putting a cream on a rash. When you inhale a steroid, it just works on the area you've administered it. It isn't absorbed into the rest of the body. All right, so here's that diagram. This is a very brief one. This is really a really basic diagram. But in terms of suppressing inflammation, up here at the very top is you have the stimulation. On the other slide, it was called the antigen. It's where everything starts. And when an antigen or something stimulates cell membranes, these membrane phospholipids liberate a couple of different phospholipids, phospholipase C, phospholipase A2, and lots of other things that are not even envisioned here. When you give a steroid, you suppress it right there. And I really should put the big red X right here. Now, this is just a little snapshot of this reaction. It's actually much bigger than that, and glucocorticoids suppress it from there on down. Whereas you can see, like the lipoxygenase inhibitors, which is another name sometimes we use for the leukotriene receptor antagonist, this blocks it appreciably further down the cascade. Histamines are not even shown here, and even non-steroidals, they also suppress inflammation, but they do it further down. So the upside of using glucocorticoid is you're not messing around. You are suppressing inflammation from the top down for someone who has an immediate inflammation in their airway that needs to be suppressed. That's a good one. The downside is you sort of wipe out everything else. It's like throwing out baby with the bathwater. So if the patient isn't like in any real acute, distress, and you're just trying to get like fine-tune a health problem, then you're safer off. Then you're safer working in areas that are further down the pathway. And this little diagram, it really doesn't do this justice. When you suppress inflammation, what you're really doing is suppressing the conversion of these phospholipids to other mediators. These two are inflammatory mediators, but there's a whole bunch of other things that the glucocorticoids also suppress that are actually really important to maintaining health, like lipids in the gut that go on to help synthesize the protective mechanism from acid exposure, for instance. So steroids are a stress response hormone. They suppress inflammation so that airways will open and you can breathe efficiently. Yes. But giving more than physiologic amounts always has a downside because, like I said, they do lots of things. I mean, remember, corticosteroids are naturally formed in your adrenal cortex. We all have cortisol on our person every day. They're necessary for normal physiologic function, like stimulating vasoconstriction, mobilizing fuel sources like glucose, promoting free water excretion so we don't become all edematous. Steroids do suppress inflammation, and they promote osteoclastic activity, which is the liberation of calcium and minerals from the bone. To some extent, we all need to be doing this all of the time. These are all balanced by other mechanisms in the body that maintain health. I mean, we have other things that promote osteoblastic activity. So there's a nice balance between minerals in the bone and minerals out of it. We have other things in the body that trigger inflammation, and then we need cortisol to help suppress it. Like everything is in a balance. We all inflame all the time, and if we didn't have natural cortisol, we'd all be a mess. Like all of you that are sitting there listening to this, chances are you're sitting up, which means you have to have probably your knees are bent, your hips are bent, maybe you're taking notes and you're using the muscles in your hands, and all of those joint stressors, they cause minuscule inflammation. But fortunately, you have cortisol on board to help suppress it. That's why your hand doesn't hurt and your knees don't hurt and your hips don't hurt. Now, if you have arthritis, they might hurt. But for most of us, the cortisol helps suppress that. So in normal physiologic amounts, corticosteroids are necessary. But when you start giving patients exogenous steroids, when we give them either PO or IV or whatever, then we really change the balance. We have a lot more steroids on board than normal. So in the lung, it's great. In the lung, it suppresses inflammation so the patient can breathe. But it also means that now we have a lot of hormone that stimulates vasoconstriction. So probably the blood pressure will go up. We have a lot of extra hormone that mobilizes fuel, so probably the blood sugar will go up. We have a lot of hormone that promotes free water excretion, so you might find that you have to pass urine more. We have a lot of the hormone that suppresses inflammation, so you can't inflame. In the lung, it's desirable. And believe me, in the joints, like anything else in the body that hurts, always feels a lot better when you're taking prednisone because it suppresses the inflammatory response. The downside is you can't, use it anywhere else that you might need it. While we're suppressing inflammation in the lung and helping the patient breathe, say if that patient is a diabetic and maybe has a small wound on their foot or they just had a toenail removed or something, we're suppressing inflammation down there too. And the patient who is already a bit compromised now can really have some trouble healing. And also, when you give too much, when you give physiologic or supraphysiologic doses of steroids, like if you give somebody prednisone 40 milligrams a day, you have an excess of the hormone that promotes osteoclastic activity. And if you do this for too long, there is a distinct concern about bones breaking down and exaggerating osteoporosis. So I'm sure I've said it 100 times already, but if I did, this is 101. The body always exists best in a balance, a steady state, typically between multiple opposing forces. When we introduce something to change that balance, like drug therapy, body's always going to try to fix it. What else we got here? Ooh, drugs used to treat cough. This is a popular one. When people are coughing, they want something to stop it. So, let's see. First generation antihistamines. Remember I mentioned this a few slides ago. First generation antihistamines do have anticholinergic properties. They cross the blood-brain barrier and they can help suppress a cough. They won't get rid of it 100%, but they can help. And in adults, these are generally, a generally healthy adult, somebody who doesn't have any risk factors for anticholinergic side effects. These are usually just fine to use. Again, anticholinergics and patient education, I know I've talked about it before. They will suppress your cough. They'll also give you a dry mouth. They may make you a little bit constipated, especially if you're already prone to it. And you might have to wait a few extra seconds for that urinary stream to get started. But it might give you dry eyes and dry mouth. Inhaled anticholinergics block some responses that can produce a cough, and that's true. They do have mild, even in the inhaled forms have mild cough suppressant activities, also generally safe in otherwise healthy patients. In fact, Atrovent, that ipratropium, the short-acting anticholinergic that I mentioned when we first started talking about this, is one of the medications that is recommended by the American College of Chest Physicians to try to help control, the residual cough that happens. Sometimes you get a URI, and you get rid of the URI pretty fast, but that cough just hangs on into infinity. They recommend Atrovent for that. Ooh, expectorants. So there's a lot of good TV commercials about this. Guaifenesin is the active ingredient in, I think it's called Mucomist. It's that commercial on TV where it's like a mucus monster dancing around and it jumps into somebody's lungs and it's all, nasty looking. Guaifenesin is the drug that helps expectorate. So here's what it does. Let's see what your handout says. Guaifenesin and its brands, the various branded forms like Mucomist, not Mucomist. That's not the word I want. So I can see the green monster, but I can't think of the name. Oh well, anyway, just Google green monster for cough medicine. You'll probably find a video. Guaifenesin and its brands reduce the surface tension of bronchial secretions, making them easier to expectorate. This is how they work. These actually are not cough suppressants. They don't make you cough any less. The idea is that they reduce the surface tension of mucus so it's more watery and you can cough it out more readily. They're called expectorants, but they don't make you cough anymore, neither do they suppress a cough. All they do is liquefy mucus, so it's supposed to be easier to get out. Because the idea is that, mucus is kind of sticky, right? Kind of like globby and sticky. And so if you have mucus a little further down in your airway and you're trying to cough it out because it's sticky, you might have to really cough to get it out. The hope was if we gave somebody an expectorant and reduced the surface tension of it, they could cough it out more easily. That's the idea. So theoretically, you're not supposed to have to cough as hard, that you can get stuff up more easily. That's the idea. I don't really know if it works or not. I know that these really used to be the first line drug that was recommended for over-the-counter cough medication, and then they've kind of fallen from grace a little bit because the same action that reduces surface tension of the mucus can also reduce surface tension of platelets and decrease their function. One of the ways that platelets maintain their stickiness is by their surface tension. And so again, in the average garden variety patient who's otherwise healthy, this probably won't make any difference at all. But if you have a patient who has any kind of platelet abnormality, this can make it worse and it can facilitate bleeding. Yes, recently the efficacy in cough has become suspect, and yeah, like I just said, avoid it in people who are on platelet medications or patients that have breathing problems. Now next we have to talk about opiate-based cough suppressants. There's a couple good ones out there. Phenergan with codeine. obviously is, it's really an old time famous one. This is marketed as Cheritusin, and there's a bunch of different. Phenergan with codeine is the generic foundation for most of them. And the codeine does suppress cough centers, so it really does suppress cough. There's also a version of this called Tussianex that has hydromorphone as the active opiate. So do they work to suppress cough? Yes, they actually do suppress it. By the same token, like almost every national guideline that makes recommendations for managing cough does not advocate using it. Because cough is a protective mechanism, truly suppressing cough really isn't advisable 99% of the time. I think I said it much earlier in the discussion. The only really time that it's appropriate to suppress cough is if the cough is truly interfering with the patient's ability to oxygenate, which doesn't happen very often. Having said that, the stuff gets prescribed all the time. So do be aware that this is also a drug of abuse. We're very much living in an anti-opiate world, and so as opiates become harder to get, people that abuse them have found a way to abuse cough medicines too. And I can't think of the name of it because I'm not old and disconnected, but if you YouTube it, like YouTube search it out, there's a whole subculture that takes these cough suppressants and mixes them with like 7-Up or some clear carbonated beverage, and then they get stoned on it. I actually did have a patient tell me once, it was a young patient, the right demographic, and he, came in and really did appear to have a URI, and so I gave him an opiate-containing cough suppressant, and then he called me and said he accidentally, spilled it down the toilet, which seemed a little odd. Accidentally spilling your drugs down the toilet is a very popular excuse that people who abuse opiates will take. If you haven't worked in that industry, it's not at all unusual for, you prescribe somebody their opiates for, whatever their acute pain syndrome, and then they call you back in a day or two and say, I was opiating them in the bathroom and I spilled the bottle and they all went down the toilet. You hear that one all the time. Interestingly, nobody ever accidentally flushes their antihypertensives or antibiotics or anything down the toilet, but, whatever. But I did have somebody once tell me that he accidentally flushed his cough medicine down the toilet. And I kind of got off the phone thinking, God, could it really be? Could he really be abusing it? And then, of course, I found out that he was. So that's the story. Often prescribed, rarely recommended. But yes, these are probably the only drugs that, anticholinergics and the first generation antihistamines a little bit, but opiate-based suppressants really do suppress cough centers in the brain. Now, moving away from cough suppressants a little bit is theophylline. Theophylline is one of those old school pulmonary medications. It doesn't really fit into any other category. It has a lot of safety issues, and so for that reason doesn't get used that much anymore. But we haven't quite gotten rid of it because it is an effective medication, and sometimes it does the job when nothing else will. Theophylline causes bronchodilation by interfering with one of the enzymes that constricts smooth muscle. So it blocks the ability of the smooth muscle of the bronchi to constrict and allows it to stay relaxed. This isn't a beta agonist. This works entirely different. So it can be used as an adjunct to a beta agonist. It is not a rescue drug. It's not something you take when you're acutely short of breath. Again, that's what a beta agonist is for. But for other conditions like COPD and asthma, sometimes this can provide the level of control that no other drug can. It's really kind of interesting. So here's what theophylline does. Actually, lots of good things. In addition to reducing inflammation and, leading to bronchodilation, which we have up here, it also decreases plasma exudate. So it decreases stuff leaking out of the blood vessels into the alveoli. It increases mucociliary clearance. So it actually helps assist that process where you trap stuff in mucus and then get rid of it. It decreases neutrophil function, decreases T cell and macrophage. These are all your inflammatory mediators. So it can decrease the amount of crud that accumulates in the alveoli and increases respiratory muscle strength. So, it does do some good stuff. I mean, the $30 million question is, why don't we use it more often? And it's mostly because there's a really narrow therapeutic index between minimally effective and minimally toxic. It requires fairly stringent levels of monitoring, and it is a cytochrome P450 substrate. So in addition to that narrow therapeutic range, it's really easy to become toxic with it. And nowadays, we just have so many other drugs that we can use more effectively that they just don't see theophylline used anymore. But it won't quite go away because, like I said, it can do things that other pulmonary drugs can't. And sometimes it is the thing that finally allows us to really get good control. So, okay, issues in patient and staff education. So now, like generically speaking, I'm not just talking about theophylline or any one particular medication. Greatest implications in understanding differences among these drugs is to facilitate understanding both among the staff who are doing the patient education and the patients themselves. I promise you, I mean, I'm sure I've said this before, you'll probably get tired of hearing me say it, but as the person who now manages the patients on the outpatient side of things, every time somebody gets discharged from the hospital, whether it's like they were in the hospital for a few days, or even if they were just in the emergency room and they were evaluated and treated and discharged, they are always told to follow up with primary care. So they always do. They always make an appointment for follow-up with me. And if I had a nickel for every time a patient came in with all of their prescriptions from the hospital and said, I don't know what to do, and they just sort of like lay them out on the table in front of me and say, I don't know what to do with all this, I'd be rich and retired, because it happens all the time. They get in, they're in the hospital, they get treated, they get better, they get discharged with a bunch of stuff, and they don't know what to do with it. Or maybe very superficially they know how to use it, but they don't know anything about what it does or why it does it or why why they're supposed to use it. And so they'll make up their own minds about what they're going to use, and a lot of times it is not consistent with the way it's prescribed. People just are so much more inclined to do what we ask of them if they understand the reason for it. It improves compliance or adherence hugely and reduces hospitalizations if patients understand what to do. So I know in the hospital nurses don't have a lot of time, but in primary care, we don't get a lot of time either. So between the two of us, if we kind of each spend a little bit of time with patient education, hopefully they can stay better longer and not be back in the hospital. Both nurses and patients sometimes don't understand why controller inhalers and rescue inhalers are not interchangeable. That is very, very true. I mean, I don't doubt it. I don't remember when it was in my world that I fully understood the differences between the two, but I know it was years after I was a nurse. I mean, this stuff is just not always that well explained to us, which is one of the purposes for a course like this. Albuterol is the rescue inhaler. Pretty much every other inhaler is not. Albuterol is really, with rare exception, the only one that should just be used when the patient is acutely short of breath. Any other inhaler that's prescribed for them, Advair, Symbicort, fluticasone, budesonide, Spiriva, Ceravent, Foradil, all of those should be used every day as they're prescribed, whether it's needed or not, whether the patient thinks they need it or not. And that reminds me now, actually, that I just said that I didn't specifically by name refer to some inhalers you may be very familiar with, like Advair and Symbicort. Advair and Symbicort, and there's a bunch of other ones on the market now, like Dulera. Those are all, none of them are rescue medications. They're all controllers, and they're all combinations. They're a combination of an inhaled steroid and a long-acting beta agonist together. So I've mentioned to you separately inhaled steroids and long-acting beta ags. Remember, like Flovent is an inhaled steroid, Ceravent is an inhaled long-acting beta agonist. Those two together in one inhaler is Advair, period. So Advair, Symbicort, and Dulera, they're just combinations. They're combination medications of an inhaled corticosteroid and a long-acting beta agonist. None of them are rescue inhalers. Honest to God, Advair is an asthma drug, and in the package insert, it has a black box warning the patients about asthma-related deaths. I mean, doesn't it just intuitively sound absurd that an asthma medication should have to warn patients about the increase of asthma death with using it? But it is true. And the reason for it is that so many people use it inappropriately because they don't understand the difference. And patients having an asthma attack will reach for the Advair and use it thinking it's going to be a rescue medication. And it's not, and they die. And enough people have died that now there is a black box warning. So that's one of the big reasons this stuff is just so important. Systemic adverse effects are another major consideration, especially of our oral drugs. A lot of patients, like, they hear about steroids, like, oh no, steroids, can do this or that. And then if their doctor tells them to use an inhaled steroid, they'll sometimes just nod their head and say, okay. And then when they go home, you're like, I'm not using that steroid because, it'll do all these bad things to me. We want people to understand that inhaled medications are not absorbed from the pulmonary tree. They just have their action in the lung, and they are very safe to use. On the other hand, some of those drugs that we do give to people by mouth, like prednisone and Singulair and all of those, they do have systemic side effects that we want people to be, to anticipate. I know I've already said this, I don't need to beat it up anymore. All inhaled drugs are not the same. Most important, make sure you understand the differences among those inhaled drugs so that then we can help the patients to understand. People, I swear, I can think of so many examples off the top of my head. I had this one lady who came into my office, she came in as an outpatient, 75-year-old lady. I thought she was going to die. I really thought she was going to die right there in the office. She was just so resting, short of breath, just sitting there talking to me like this. She's like, oh, honey, I think I'm going to die. And I'm thinking to myself, well, I think you're going to die too. So, could we take you somewhere else? But she was absolutely adamant that she was not going to the hospital. And that first day, I couldn't get her into the hospital. The second day I did, because I tried everything I had and she didn't get any better, and she went in the hospital. So she goes in the hospital. She went there for 3 days. Truth was, they weren't entirely sure what was wrong with her either, but they did send her home with some new medications and a couple of new inhalers. And one of them was a new albuterol inhaler, and it was a weird delivery mechanism. It didn't look like a traditional inhaler. I had never seen anything like it. So anyway, she goes home from the hospital with this thing, has no idea how to use it, and 3 days later winds up back in my office again looking like she's going to die, just so short of breath, because she didn't know how to use the inhaler that they sent her home from the hospital with. And in the first few days, she was just too sick to even find her way back to me. So one of the many, many reasons for rehospitalization after a pulmonary disease is that patients just don't know how to use the drugs that we gave them. In case I didn't mention it, only one rescue inhaler in the world. Only one drug, not one inhaler, one drug is a rescue medication, and that is the short-acting beta agonist. There's one for all occasions, right? Albuterol, Livalbuterol, Preventol, Ventolin, ProAir, there's a ton of them. But short-acting beta agonist, that's what they are, and that's what the patients should be taught to reach for when they are acutely short of breath. The controller inhalers are not rescue inhalers, and the controller inhalers are everything else. As a point of interest, anybody who has asthma should have a couple of inhalers on their person. The albuterol inhaler is that rescue inhaler. And if you think I'm being repetitive with you, oh my gosh, you should see with patients. I'll sit there in the office with them, and I'll have the short-acting beta agonist in one hand and the steroid inhaler like budesonide in the other hand. And I'll sit there with them and say, this is the one you use every day, every single day, whether you think you need it or not. I always tell patients, stick it in the bathroom and make it part of your bathroom routine. You get up in the morning, you stumble in the bathroom, urinate, wash your hands, use your inhaler. Then brush your teeth and rinse out your mouth. Because remember, anytime a patient uses an inhaled steroid, there is the potential for oral thrush because the steroid suppresses inflammation in the areas it touches, and it can suppress normal healthy bacteria in the mouth, and they can develop mouth fungus or thrush. So after any inhaled steroid, they should be rinsing. So that's what I tell people. Get up, go pee, wash your hands, use your inhaler, and then brush your teeth. And then at night, before bed, go in the bathroom, urinate, wash your hands, use your inhaler, and brush your teeth. And that way they're using their inhaler twice a day as prescribed, and they're brushing their teeth in the bargain, right? And rinsing out their mouth. Inhaled anticholinergics, we have the long-acting one and the short-acting one. Ipratropium is marketed as Atrovent, that's your short one. Tiotropium is marketed as Spiriva, that's your long one. And these primarily used for COPD. And these you don't have to rinse out your mouth. I mean, you might want to if it tastes a little funky in there, but these aren't steroids, so these don't suppress bacterial growth and won't give you thrush. The long-acting beta agonists, yes, they are beta agonists, but they are not rescue therapy. So salmeterol and formoterol, marketed as Ceravent and Foradil, these are not things that we use when you're acutely short of breath. They are also meds that you use every day. Oh, and here's the combination agents I was telling you about. I'm glad. I felt like I hadn't talked about it, and I think it was important to do that. So you remember everything I said about Advair, Symbicort, and Dulera. Do not use ever as rescue therapy. Advair has been so commonly used by patients that they die, and now there's a black box warning. Now we've got a couple of other combinations. We have the long-acting beta agonist anticholinergic combination. This you'll probably almost never see anybody on these because they're really expensive, and insurance companies never want to pay for it. But Anoro Ellipta and Spialto Respimat. Don't you love those names? Like whoever came up with those names, I don't know. It seems like they could do better for all the money they make. Those are a combination of like Ceravent and Spiriva together, and they are appropriate because those are the two drugs that we like to use together in patients with COPD. So I just threw them here in the event that you ever run across a patient who's on them. If you come across a patient who's on this, you can bet that their COPD is probably pretty significant. And then the last drug class, again, you probably won't see a whole lot of it, but this way you'll be familiar with it if you do. This is, the generic name is Roflumilast. This is marketed as Dolaresp. And this is an oral agent for severe COPD. If you see somebody on this, they really are at like the end of the road, the end of the treatment trajectory anyway for COPD. This is an oral drug, and really what it is like a better, safer version of theophylline. It's like, think of it as like 21st century theophylline. It does everything theophylline does, but better, and it doesn't have the same safety and side effect issues. There is a warning about suicidal ideation, and I genuinely don't understand that, so I can't tell you why. All I can tell you is it's there. And, may cause weight loss, which, again, in somebody with late-stage COPD, this can be pretty significant because usually they tend to be a little bit more, emaciated anyway, because just the struggle of breathing when you're chronically hypoxic will burn calories faster than anything else. So there are these things to be watchful for, but Dolaresp is something that isn't usually prescribed unless the patient is really in pretty much at the end of the road anyway. So like everything else, it's always a risk-benefit analysis. But these folks really they need to be monitored for suicidal ideation. And that doesn't mean that every time you see them, you have to say, are you suicidal? But you do want to be alert at every encounter for changes in mood or new onset depression, stuff like that. And be watching their weight because COPDers don't need to be losing weight at all. So I think that's all I've got. I hope it was helpful, and I'll see you next week.